I have the pleasure of introducing Dr. Rodney Franklin. He's a National Congenital Heart Disease Audit Consultant and a pediatric cardiologist from the Royal Brompton in London, England, and has made really tremendous contributions to our field in looking at how to develop databases and registries and compiling data and analyzing it for the purposes of quality review and improving outcomes. So, Rodney.
Thank you. It's a great pleasure to be invited here, and this is perhaps an unusual, perhaps unsung topic of innovation. As you know, for my topic was nomenclature, quality improvement, and all of these items here are things which would be vital for a multi-institutional outcomes analysis. And I would give it to you that only one of them really leads to all of the others. Without a common language of nomenclature and coding, we would not be able to achieve any of the other things mentioned here, such as risk stratification, evaluation of morbidity, complications, and so on, to compare the survival of our patients in terms of quality assurance and leading to quality innovation later on. In fact, the subject of nomenclature started over 160 years ago when quoted by William Farr, a medical statistician in London in 1839. The advantages of a uniform statistical nomenclature are so obvious that it is surprising that no attention has been made to its enforcement. Each disease has been noted by 3 to 4 terms, and each term applied to as many different diseases. Vague, inconvenient terms have been employed, as we have seen over the years that we've been training in pediatric cardiology over the last 40 years or so. Nomenclature is as much important in this department as weights and measures in the physical sciences and should be settled without delay. 160 years later, pediatric cardiology began this process in earnest. There were 2 simultaneous publications in Cardiology in the Young, the results of work which actually began in the Royal Brompton, where I now work, in 1985, and Bob Anderson was involved in this as well as Michael Rigby, producing the Brompton codes in 1985, about 660 diagnosis codes. This was taken up by Dutch people like André Moulard and was expanded in the 80s and 90s. And then it was incorporated by or taken on by the AEPC, Association for European Pediatric and Congenital Cardiology Coding Committee, and was published in 2000. Across the Atlantic, in a much more surgical field, a similar process went on, unbeknownst to us in Europe, by the International Congenital Heart Surgery Nomenclature and Database Project in 1998, and published in Annals of Surgery their version of a nomenclature for pediatric congenital heart disease. The 2 teams involved met in Frankfurt in October 2000 and realized that these 2 systems needed to be mapped together and work together, and this produced the International Pediatric and Congenital Cardiology Code. This then led on to a cross-mapping process over the next 10 years or so to produce a mapping between the 2 systems. So my innovation is the International Pediatric Congenital Cardiac Code, which continues, and the innovators involved in this, and I'm going to read these so I don't forget them all, are the 12 people who originally did all the work on this, inspired, if you will, by Martin Elliott at that point to get together. They are Vera Aiello, Marie Bellond, who's here with us today, Steve Colan, Bill Gaynor, Jeff Jacobs, of course, Otto Krochman, Hiromi Kurosawa, Bogdan Marozewski, Giovanni Stellan, Christo Chevenkov, who became the president after Martin Elliott, and Paul Weinberg. And to these people, I owe the credit should go for producing this International Pediatric Congenital Cardiac Code. As part of the process of doing this, we had to unify nomenclature and terminology, and as you'll see here, Bob Anderson and Dick Van Praag in 2001 at the World Congress at that point agreed that the terminology should be mapped and coordinated together, and this process has been successful, even though there's still some controversies such as ventricular septal defect, which you may have heard earlier on in this Congress, which continue. Now, this IPCCC has been incorporated into over 1 million patient procedures across the globe in different databases. Our own in the UK includes catheter interventions as well as electrophysiology procedures as well as surgery, whereas the others tend to be mostly surgical. And this has led to evidence-based risk stratification due to accumulation of data, such as the STAT score used by the STS and the ACTS, and our own partial risk assessment in surgery in the UK, or PRAISE. So we now have the IPCC incorporated into some parts of the SNOMED, as well as the International Classification Disease by the WHO. We spent the last 6 years creating terms which allow this to happen, with 319 congenital cardiology terms now in ICD-11, which should be coming your way in the next year or so. This has led to great quality improvement initiatives and advanced our field because of the underlying common nomenclature. This has allowed us to identify positive and negative outliers and facilitate institutional collaboration to improve outcomes, or gives that opportunity. It allows learning from best practice, and we're now looking at morbidity such as post-procedural complications. It's also enabled us to improve antenatal diagnosis in the UK by naming and shaming units, in that if they haven't been successful in diagnosing congenital heart disease in the first, which led to an intervention in the first year of life, then that they've been shown in our regional areas, and there's been a consistent improvement over the regions over the subsequent years. So there's an improvement in outcome and quality as a quality improvement metric. And going forward, the future shows us that by using ICD-11 or other coding systems and amalgamating databases so that the same names are used within the electronic health record and mapping to other systems, we should have harmonization of data, which should allow us to further improve using, for instance, the 21 quality metrics produced by the Jeff Jacobs paper back in 2012. So I would like to summarize and say that, that the innovation is the IPCCC, and the innovators are members of the International Society for Nomenclature and Pediatric and Congenital Heart Disease. Thank you.